second speaker is Dr. Seth Furgeson. He is an associate professor in the renal division. And I know Dr. Ferguson quite well, as he did his research in my lab as a child. He received his medical degree at Baylor College of Medicine and completed his postgraduate training at WashU, followed by his fellowship here. He is currently a nephrologist at Denver Health, where he serves as medical director of outpatient dialysis. He is also the associate program director for nephrology at our university, and his research focuses on pathogenesis of chronic kidney disease with a special focus on leukotrienes in preclinical mouse models. He is also a co-principal investigator of a clinical trial studying the effects of Cysteinyl Leukotrienes in patients with type 1 diabetes and chronic kidney disease. Dr. Ferguson.
Thank you so much, everyone, for coming. And I'm going to just give a brief overview of the major project we have going on in our lab right now. So first, I'm going to talk about some of our earlier data on this project, where we looked at a class of lipids known as leukotrienes and their role in CKD. And the second part of the talk, I'm going to cover some of our more recent experiments looking at a specific type of leukotriene known as the Cysteinyl Leukotrienes and their critical role in mediating the transition between acute kidney injury to chronic kidney disease. So why study CKD progression? Well, I think as most people probably know, there are a large number of patients in this country who have chronic kidney disease. On the left side of the chart, you can see data from the CDC website, just looking at the epidemiology. And as you can see, there's over 10% of people in the United States do have chronic kidney disease. Obviously, when you get to the older age group at 65 plus, the prevalence is very high. It affects all groups, although there is certainly a disparity, and it does affect non-Hispanic Blacks more than other groups. And this causes significant morbidity, affects patients' quality of life, is associated with tremendous cardiovascular mortality. So it is a very heavy disease burden. And one of the most feared complications you can see on the right side of the chart is the number of patients in this country who develop end-stage renal disease every year. So you can see over the last 20 years, every year, over 100,000 Americans develop end-stage renal disease, which either requires dialysis or a kidney transplant. It did appear to be increasing. Maybe if you're optimistic, you can see a plateau and hopefully we'll see a decrease. But this is associated with significant morbidity. And end-stage renal disease is obviously a pretty devastating complication. So the goal is to find ways to treat chronic kidney disease and prevent progression and improve patients' quality of life with chronic kidney disease. Things are a lot better in 2023 than they were maybe 30 years ago. We have evidence-based therapies that prevent CKD progression. This is a recent trial looking at SGLT2 inhibitors, it's called the DAPA-CKD trial. And what you can see here is just looking at the renal specific endpoints. And so this means patients either had a 50% reduction in their kidney function or they went on dialysis. So if you take patients who are high risk, like with CKD and protein in their urine, and you follow them in the placebo group, 16% of them actually have that endpoint in under 3 years. And the SGLT2 inhibitors are great. They reduce it by 50%, a great therapy, but you can still see that there is a lot of room for improvement in the year 2023. There's still a lot of patients, despite the best therapy we have, RAS blockade and SGLT2 inhibitors, who still develop progressive CKD and either go on dialysis or need a kidney transplant. So in 2023, we still need more therapies, either for patients who can't tolerate this therapy or for patients who still have that high residual risk of developing end-stage renal disease. And so what happens in chronic kidney disease? Why does a patient go from mild chronic kidney disease to progressive chronic kidney disease needing dialysis? Well, as most people may probably do know, different diseases can cause chronic kidney disease. In the US, diabetes is by far the most common, but there are many kinds of chronic kidney disease. They do seem to share common pathophysiologic events, though. So, one event that is pretty much universal is that there is what we call interstitial inflammation. So, instead of having all those nice epithelial tubules in a healthy kidney, what happens is you get macrophages and lymphocytes interspersed in that area. You get significant epithelial damage in the kidney. The kidney is mainly epithelial cells. These tubular epithelial cells undergo epithelial to mesenchymal transformation. They undergo metabolic changes where they use more glycolysis and less oxidative phosphorylation, and they become senescent. So they're not capable of repair or recovery if there are any kidney injuries. And the last, what's commonly called the final common pathway is interstitial fibrosis. So instead of having those nice, healthy epithelial tubules, you have collagen, fibronectin, scar tissue in there. And that's generally irreversible injury. And the two therapies that are commonly used to prevent CKD progression are RAS inhibitors. So those would include angiotensin converting enzyme inhibitors or angiotensin receptor antagonists, and what are called SGLT2 inhibitors, which prevent sodium and glucose reabsorption in the proximal tubule. And we don't 100% know exactly why these therapies are beneficial, but there is data that they target all three of those processes. However, it's not really clear how much they target interstitial inflammation, for instance. And I think what's generally considered to be a promising area of research in preventing CKD progression is actually targeting this top event, specifically targeting macrophages or lymphocytes that might be contributing to this epithelial damage. So our lab is interested in actually studying that specific event, how interstitial inflammation leads to CKD progression. And here's kind of the working model that we kind of based this project on. And so the working model would be that in the kidney, you get these renal tubular epithelial cells that are damaged from whatever injury like diabetes or ischemia. That causes bone marrow derived inflammatory cells, monocytes, to come to the kidney. And then what happens is you can have multiple potential fates. You can get great epithelial repair, inflammation can go away, but more commonly what happens is you get macrophages in the tissue sitting right next to epithelial cells, and you get this crosstalk that promotes maladaptive repair. So macrophages probably make certain molecules that are injurious to the epithelial cells. The epithelial cells get injured. They eventually undergo an irreversible form of injury and cell cycle arrest, and they become senescent. Then they secrete molecules back to the macrophages, and you kind of get this feed-forward maladaptive process that drives CKD progression. So the goal of the project today is what we're trying to define are some of these factors that are released by the macrophages that hurt the epithelial cells, and they promote this kind of feed-forward pathogenesis in kidney failure. So the pathway that we study in our lab is the 5-lipoxygenase pathway, which is responsible for the synthesis of a class of eicosanoids known as leukotrienes. And so 5-lipoxygenase is most active in inflammatory cells like macrophages and neutrophils. And what happens is, in the presence of some kind of inflammatory stimulus, this enzyme called cytosolic phospholipase A2 cleaves membrane phospholipids. And then right here, the 5-lipoxygenase and its affiliated enzyme catalyze the production of leukotriene A4. Leukotriene A4 can have two different fates. It can be metabolized by this enzyme, leukotriene A4 hydrolase, it's something called leukotriene B4, which has certain cell surface receptors and mediates specific pathogenic events in inflammatory diseases. Or it can be metabolized by LTC4 synthase to make a group of leukotrienes known as the cysteinyl leukotrienes, which bind to different cell surface receptors on different cell types. And so in a lot of organs like the lung, liver, et cetera, this pathway is highly activated in macrophages and neutrophils, and it does mediate epithelial damage, tissue injury, and fibrosis. And so when we started this project, our question was, what is the role of this pathway in leukotrienes in kidney injury? There is some data in humans that this pathway is important in chronic kidney disease. This is a prospective trial known as the CRIC study, which studied patients who have chronic kidney disease. And these investigators from the University of Michigan basically did lipidomic approaches in serum at baseline in all the patients in the CRIC cohort. And they looked at specific pathways of lipids and classes of lipids. And so in the CRIC study, you have patients who progress, and you have patients who don't progress with their CKD. And what they did was they kind of found a dose-dependent association with baseline 5-LO or leukotrienes and their risk of progression. So you can see the bottom quartile, the lowest level of leukotrienes have the lowest risk of CKD progression, and the highest level of leukotrienes have the highest risk of CKD progression. So the hypothesis for our project was that if you inhibit 5-lipoxygenase, you're going to reduce renal injury and fibrosis in mouse models of CKD. And I wanted to just briefly review the mouse models I'm going to be showing in this presentation. It would be ideal for a CKD researcher if we had a perfect mouse model that replicated the human disease. And obviously, since diabetes is the most common cause of kidney disease, it would be great if we had a great mouse model that replicated the human disease. We don't have it. The diabetic models in mice, they don't really get significant kidney injury, and it's very hard to test potential therapies for CKD in mouse models of diabetes. So what investigators usually do is they try to model one or two of these crucial events in CKD, and most investigators try to use different kinds of models so they can get more robust findings about pathogenesis of CKD. So you might, if you read the literature, you'll read about a remnant kidney model, which is basically surgically removing 5/6 of the kidney mass. Obstruction, and I'm going to show some data with this model. Basically what one does is it's called a unilateral ureteral obstruction. I'm going to call it UUO after this. You tie off one ureter so that that one kidney is completely obstructed. The other kidney is normal though, so that can serve as your own control. It's a high throughput model. You don't have to use as many mice because you have the control kidney. But the major limitation is that they don't get renal dysfunction because that one kidney still works well. There's an ischemia reperfusion model. And then commonly used are these toxin-induced models. And they all are pretty similar. It's basically something that causes epithelial death and injury in the kidney, and that they get a really severe acute injury, and then they get some recovery afterwards. I'm going to talk about the folate nephropathy model, but you can also use different toxins like ursolithic acid or adenine. There are genetic models that replicate human disease like polycystic kidney disease and Alport's. And then there are many models of glomerulonephritis. But none of them replicates everything that one would see in human kidney disease. Some of them predominantly just give you tubular injury, no proteinuria. Some of them give you very significant proteinuria, but not a lot of chronic kidney disease. So they all have their limitations, which is why most researchers in general use multiple models to try to validate a specific target. And so the first question we of course asked was, is 5-lipoxygenase even around in our models of fibrosis? So this is a section from a unilateral ureteral obstruction kidney, and we did serial sections from paraffin FFPE tissues because there's not a real good antibody for immunofluorescence for 5-LO. And you can see here, so the blue areas are fibrotic areas. So you can see in these large fibrotic areas, there are a lot of cells that express 5-lipoxygenase. And if you do a stain for F480, which is a macrophage marker, most of the cells that are 5-lipoxygenase expressing are also macrophages. So right off the bat, there at least is evidence that 5-lipoxygenase in macrophages is present in kidney injury in these CKD models. And I'm going to go through all the data of our studies, just a little background in how I'm going to look at kidney injury and fibrosis. So we wanted to test whether inhibiting leukotrienes reduced renal disease progression. And the major metric we're going to look at is tissue fibrosis. I do it a little differently, I think, than people may be familiar with. We use a microscope in the advanced light microscopy core to do second harmonic generation, because fibrillar collagen are these heterotrimers that have this very unique property where they can take 2 photons of a certain wavelength and emit a photon of exactly half that wavelength. And so it's a very specific and sensitive technique. Also helps you keep your sample size low in these experiments. So all the data I show you on fibrosis is going to be using this technique. So the first question is, if you inhibit leukotrienes, do you get less fibrosis? And so we gave a pharmacologic, FDA-approved 5-lipoxygenase antagonist to mice receiving UUO. And on the left, you see a normal kidney. And what you see in a normal kidney, these are autofluorescent tubules. You can see they're big, kind of plump tubules. They're back to back. There's not a lot of space or cells in between them. If you tie off the ureter on that cell type and you go 2 weeks, you can see that there's a lot of atrophy. First of all, you don't get those big plump tubules anymore, but you get a lot of red in the space, and that's fibrosis. And if you pre-treat with a 5-lipoxygenase antagonist, so this inhibits all leukotrienes, leukotriene B4 and cysteinyl leukotrienes, you get less fibrosis. So this is the first piece of data that that we had, that inhibiting leukotrienes could prevent renal disease progression. So we went a little further down looking at another model, and this is the folate nephropathy model. And the nice thing about this model is that you actually can look at renal function too. And we had genetically modified mice that didn't have leukotriene B4, that would be these LTA4 hydrolase knockout mice, and mice that didn't have cysteinyl leukotrienes, which would be the LTC4 synthase knockout mice. And then interestingly, they were both protected from developing fibrosis. Again, this is a normal kidney. The tubules are back to back, not a lot of fibrosis. You can see here, you lose, this is 84 days after folate. So you lose a lot of that kidney architecture at that point and a ton of fibrosis. And not only is there less fibrosis in the knockout mice, but you can see that they're not normal, but they do maintain some of that kidney architecture, some of that tubular epithelial health. Like I said, you can look at renal function in these mice. And so the nice correlate is looking at the plasma BUN, and they both have improvement in their renal function. So pretty good data that inhibiting leukotrienes, either LTB4 or cysteinyl leukotrienes, prevents renal disease progression. Just briefly, so that's looking at fibrosis. We have a collaborator, Evgenia Dobrinsk, who also is interested in using advanced microscopy techniques to look at other pathophysiologic events. And so we wanted to see whether or not we could use a technique known as FLIM to determine if these leukotrienes actually induce maladaptive epithelial metabolic changes. And FLIM is a technique where you can actually use on intact kidney tissue, and you can basically use it to see if certain cells are undergoing a glycolytic shift. Because remember, one of the maladaptive metabolic changes in CKD is that the epithelial cells go from oxidative phosphorylation to glycolysis. So the way FLIM works is that instead of conventional fluorescent microscopy, where you just look at the intensity of the signal, it measures time for that fluorophore to decay. And you can use endogenous molecules like NADH has autofluorescence, and NADH has its own characteristic decay time. And you can actually set up the assay so where you can detect a difference between enzyme-bound NADH and free NADH. So you can see that switch from oxphos to glycolysis. So here's a quick example of the experiment. These top panels, these are just fluorescent intensity images, so you can just see the part of the kidney we're looking at. This is the phasor plot where we basically you can take the lifetime pixel by pixel and plot it along this trajectory. So the closer the color transform is to this purple red, the more likely the cells are undergoing oxphos, and the closer it is to this white signal, the more likely they are undergoing glycolysis. So here's a nice normal kidney. The proximal tubules are mainly undergoing oxidative phosphorylation. When you induce a unilateral ureteral suction, you can see that there's a pretty large shift to glycolysis. And it's partially, not completely, but partially abrogated if you pre-treat with xyloton, which is the F5LO antagonist. Here's the graphical demonstration of the data. You can see the right kidney is the UUO kidney. So when you induce a UUO, you shift it glycolysis this way, and you partially bring it back with xyloton or the leukotriene antagonist. So just an interim study of these studies, we showed that 5-lipoxygenase, which makes all leukotrienes, is expressed by macrophages in mouse models of fibrosis. And the 5-lipoxygenase pathway specifically seems to promote fibrosis and these maladaptive epithelial metabolic changes. Okay, so I've got a few minutes to talk about our more recent data, which is not published yet. And it's looking at cysteinyl leukotrienes in a model of AKI to CKD. So, if you inhibit all leukotrienes, the next question that certainly comes up is which leukotrienes and which receptors are most important. So like I said, there are two major classes of leukotrienes, LTB4 and cysteinyl leukotrienes. The cysteinyl leukotrienes have two major receptors, cis-LTR1 and 2. Cis-LTR1 is highly expressed on leukocytes. And our early studies, which I'm not going to show that there's very little cis-LTR1 in a normal uninjured kidney. But if you induce these injuries, it gets dramatically upregulated in the epithelial cells and in the macrophages. So it does seem like a good target for chronic kidney disease. And so the goal of this part of the project was that if you inhibit cis-LTR1 during a short period of time, right after you induce kidney injury, that might prevent maladaptive epithelial repair, and it might prevent chronic inflammation. So we used a drug called montelukast. Some of you may know that as a Singulair, which is a FDA-approved drug for asthma. It is also an antagonist of cis-LTR1. And our question was, if you go back to our model, right after you induce epithelial injury, you get that crosstalk between macrophages and epithelial cells. And we reasoned that there is probably that crucial period of crosstalk where maybe you could inhibit, and then you will kind of redirect the fate of the injured kidney more towards a healthy epithelial repair. So we induced the injury. After we induced the injury, we gave the montelukast or a vehicle by gavage just for that 10-day period after the injury. And then we just let the mice go for a long time. And we did actually find that cis-LTR1 was pretty important mediating that CKD progression. Again, here's that uninjured, perfectly looking kidney. You can see here with folate, you get this real patchy epithelial atrophy. So you got some areas that look kind of normal and areas where there's a lot of atrophy and just a lot of fibrosis. And you don't totally reverse it with the montelukast, but that is a pretty significant improvement in renal architecture and a pretty significant reduction in fibrosis. Here's the quantification of the fibrosis on the right. And we do have kidney function again, so you can see the BUNs basically go from 60 to below 40. So that is a pretty significant improvement in renal function. So that was a pretty large, pretty significant phenotypic change. The next part of the project was to try to figure out exactly how montelukast, was preventing CKD progression. So we have done bulk RNA-seq on the homogenized kidneys. Here's the volcano plot. So you can see that in the montelukast versus non-montelukast treated kidneys, there is a large number of differentially regulated genes, both upregulated and downregulated. The pathways that are negatively regulated by montelukast are mainly pathways involved in the immune response. Here's the heat map of that first pathway, activation of the immune response. So you can see we have 5 mice in each group, and there is a pretty nice separation. Here's just validation that inhibiting montelukast early in the injury prevents chronic inflammation 87 days down the road. So this is the injured kidney. You can see this is CD8 marking for macrophages, and you can see a lot of these tubules are basically surrounded by macrophages. You still do get some macrophages with the montelukast group, but it is significantly better. So a large improvement in kind of this chronic inflammation that's associated with CKD. And this kind of goes back to the first part. A lot of the pathways that are improved by montelukast are metabolic pathways. So, cellular respiration, oxidative phosphorylation, electron transport chain, and everything. And this, this is kind of a hallmark of healthy proximal tubular cells. So kind of what it says to me is that you are allowing those proximal tubular cells that were injured to kind of have that healthy repair and grow back into healthy tubules where they are able to utilize those normal healthy metabolic pathways. All right, so that's a brief summary of this project. So kind of what I showed is that that macrophage-induced 5-lipoxygenase activation promotes epithelial injury and fibrosis in 2 models of CKD. And post-acute kidney injury, if you just inhibit leukotrienes during that critical period of epithelial repair, that can reduce renal injury and prevent significant CKD. The data also seems to show that cysteinyl leukotrienes themselves are a critical mediator of chronic inflammation post-acute kidney injury, and cysteinyl leukotrienes may also promote maladaptive epithelial metabolism post-AKI. So we're still doing mouse studies, trying to hone in on specific pathogenic events, but we did use some of this data to support our application for a JDRF grant to look at leukotrienes in patients with CKD. And this study is activated and ongoing for those of you who have patients with type 1 diabetes and chronic kidney disease. And it's a randomized controlled trial with montelukast or placebo, looking at some surrogate endpoints of CKD and renal inflammation. And that's it. Thanks so much for your attention. These are the collaborators on the left side, and Rafe and Mary have been mentoring me since I was a fellow, and then some of the collaborators on the clinical trial. And then also I'm greatly appreciative of the financial support from the renal division in Denver Health. Thank you.
Any questions?
As somebody who uses these drugs every day, I never thought about kidney function. But in asthma, montelukast is like an everyday drug.
Right.
I've always thought like the FLAP inhibitors are more powerful anti-inflammatory drugs. Do you think like maybe those effects will be more robust using xylutone instead of montelukast?
Yeah, you would. That is likely. The one issue with the FLAP inhibitors is that when you inhibit that far upstream, you also prevent synthesis of some, good lipids like these pro-resolving mediators, et cetera. And so, getting the receptor downstream is theoretically more, more advantageous because you wouldn't affect the synthesis of good lipids as well.
Got it. Thank you.
You are. Are the FLAP inhibitors currently being used?
Yeah.
It's a very small company. They're hard to get. It's very expensive, and the pills are the size of a torpedo.
They have a black box warning too on liver dysfunction too. So.
Yeah, we monitor liver function.
Yeah.
I want to thank everyone.
Yeah. Thank you.